I'd like to thank our first panel on social determinants. I think they did a very good job of setting us up to talk about precision medicine, which is our current session. As many of you know, while we talk about precision medicine, we're talking about a host of different things, which includes the incorporation of both genomics and technology into healthcare. Now, precision medicine, as the term that we use today, was introduced in 2015 by President Barack Obama with the Precision Medicine Initiative. And the idea is that through use of genetics and information technology, we would be able to enable healthcare through diagnostic tests, which allow us to precisely predict, prevent, diagnose, prognose, and treat and monitor disease. So when we talk about precision medicine, we're talking about inclusion of very customizable individual aspects of our care into a healthcare, which allows us to disseminate it across a broad band of services for individuals. So this happens specifically through genetics, but a variety of different biomarkers. And this idea is that these biomarkers can become identification of genomic variants through samples of DNA, either through blood, urine specimens, tissue specimens, that we can look at your DNA and that we can create a panel of tests that allows us to identify individual characteristics for disease. And so this is how we're able to customize disease. Now, originally this was an idea, but increasingly we became gaining the capabilities to do more and more of this. However, there are those who have tempered excitement for precision medicine. Specifically in 2012, Dr. Charles Rotimi from National Institutes of Health wrote an article in the Personalized Medicine stating why precision medicine, or personalized medicine as it was called then, will fail if we stay the course. The idea there is that there isn't enough research across diverse populations to really predict how any of this would affect individuals or to make it generalizable. More recently, in the MIT Technology Review, there was an article called "Why White People Only DNA Tests Show How Racist Healthcare Has Become." So there's a lot of concern here about precision medicine, about the use of these technologies, about the use of genomics in healthcare, and how it will affect care of Americans. So as we think about that, specifically Dr. Charles Rotimi's article, they were talking about the lack of research. And I want to give everyone a little bit of context about the lack of research. So here we have research across two public genetic databases, which are the Genome WAS Association Study Catalog, as well as dbGaP, which are both databases held by the NIH, which catalog all genetics research. And here we have, if we look at the current world population highlighted here, we can see that the current world population is under just around 15% European. However, if we look at the genetics catalogs, we look at the databases, and we can see that the research is overwhelmingly based in European populations. And we juxtapose that to, or break that down to all the populations studied by separating non-white populations to include those that weren't categorized, underrepresented minorities, and Asians. We can see that a very small fraction of the research is actually based on Latinos, African Americans, Native Americans, underrepresented populations in the US, and is not reflective of their representation in the US population. This is giving a lot of concern about what we know in terms of genomics, what we know in terms of technologies, and how these will be applied to diverse populations. Essentially here, all that we know about genomics is really based off of European populations and European genetics. So with that, we'll start our panel, and we're going to talk about what precision medicine means for minority health. With that, I'd like to introduce our panel, starting with Justin Hentges from the National Institutes of Health, specifically from the Precision Medicine Initiative's All of Us program, which is the NIH cohort, followed by Adolph Falcon from the National Hispanic Alliance, and Millicent Gorham from the National Black Nurses Association, and then with Dr. Gerren Wilson from Genentech. Thank you.
Okay. Good morning. My name is Justin Hentges, and I'm the Director of Finance and Operations for the All of Us Research Program at the National Institutes of Health. It's my honor to be here today with you all. I do want to send my director, Eric Dishman's regards. He wishes he could be here, but he is stuck in Oregon right now. I wanted to just give a quick overview of the All of Us Research Program. And as Dr. Landry stated, what is precision medicine? It's this emerging approach to health that takes into account the unique characteristics of an individual. And so All of Us is our historic effort, longitudinal effort to gather data from 1 million or more diverse people in the United States. And our goal here is to enable researchers to discover paths towards delivering precision medicine. Our mission is to accelerate health research and medical breakthroughs, enabling individualized prevention, treatment, and care for all of us. Now, the program can be used to explore many potential scientific opportunities. The slide lists some of them. So this could be estimating risks by integrating environmental exposures and biological factors, developing solutions to health disparities across populations, and empowering participants with information to improve their own health. On this last point, many of us also have a personal connection, whether it be for ourselves, our families, or our friends, to imprecise medicine, where the common response to a health event was not the right response for us, where we might not have had the right information to help determine the best course of treatment. By having All of Us as a resource, and by developing approaches to take into account our uniqueness, we're moving away from this old model and into a new, more precise treatment world. But what makes All of Us different from other longitudinal studies? Obviously, the sheer size, we're looking at 1 million people in the United States, but that's not all. We believe we're building transformational approaches that will benefit the program and the entire research enterprise. Now, we have 8 core values that drive our decision-making in this program. These are something we think about every day. How does this align with our core values is something you will hear in our office and across the consortium as we make decisions. I want to highlight a couple of these values and the way we believe they are transformational for our program and for research in general. And first, diversity. Diversity is key to this program. We're committed to building trust and engaging with communities that have been historically underrepresented in biomedical research. Currently, more than 75% of our participants identify as belonging to one or more UBR communities, and approximately 50% identify as being to a racial or ethnic minority community. We're also committed to ensuring that this program is available across the country. So regardless if you're here in Washington, D.C., if you're in Tucson, Arizona, or if you're from my small hometown, Shawano, Wisconsin, this program is about everybody in the nation. The more diversity we have in demographics and geography and health status and in the data we collect means this resource will be more valuable, the research will be more valuable, and the discoveries will be for all of us. Another transformational approach is that our participants are partners. They are not patients, they are not subjects. They are true partners in this endeavor. They help us think about things like what data we collect, what lab assays we run, how research is conducted, what types of research is conducted, and how their data gets returned to them. They're involved in every aspect of this program. And finally, another transformational approach and one of our core values is about data access. This resource will be available to all types of users, from the researchers at major research universities, to community college classrooms, to citizen scientists. Of course, we have privacy and security safeguards in place, including a tiered system for researchers to access different data types. But this is a national program, and we want to make sure the resource is available to the nation to solve very pressing questions. Briefly, just take you a moment to describe the program building blocks and our participant experience. Now, in a little less than 3 years, we have built the infrastructure necessary to launch. We nationally launched this program in May of 2018, and to maintain this program. And we continue to build additional aspects, like our recent development of our genome centers that are going to be doing the genotyping and the whole genome sequencing on our participants. In particular, I also want to bring your attention to our community and provider network, some of whom are represented here today. These trusted partners are helping us bring all of us to diverse communities and helping us build respectful, trusting long-term relationships that we know we need to be successful. Now, what is a participant experience like? Well, first, anyone can join at allofus.org and complete many of the enrollment activities online. Now, this includes the enrollment, but also consenting to the study and authorizing access to your electronic health records. It also includes answering a variety of surveys about overall health, lifestyle, family history. Next, you may be invited to contribute physical measures and biosamples. Currently, these activities take place at one of our healthcare provider organizations or enrollment centers. But we're also working on methods to collect that information without people needing to come to a physical site. And if you choose, if you have a Fitbit, you can also authorize us to have access to your Fitbit data. And we're working on other wearables and having folks be able to provide that information as well. Now, as of April 2nd, we have over 200,000 registered participants, and over 126,000 of them have completed the protocol, so that first stage. Again, more than 75% of our participants are from underrepresented and biomedical research communities. And we're also, as you can see, looking towards the future and continuing to launch new activities, in particular activities that get us to a broader audience and provide more inclusion for the program. And so thank you. I look forward to the discussion today.
Thank you, Justin.
Do you guys have slides? No? Okay.
Mr. Falcon.
Well, good morning, everybody. It's a pleasure to see you here. And first of all, I have to congratulate Gary and NMQF for, again, including this as a featured topic in their program. I thought I'd just take a few minutes to let you know why at the National Alliance for Hispanic Health we're so heavily invested in this program. It's about 12 years now ago, we published a report called Genes, Culture, and Health. And we have always seen this as the future of health, and we're thrilled to be here at this point, finally. But one of the reasons we're really involved with this is pretty simple. We were invited. Now, I don't want to gloss over that. As many of you in this room know, because you fought the battles with us, we've had decades of legislative requirements that NIH and FDA adequately collect data in a way that would produce results in clinical trials for Hispanics, for African Americans, for Asian Americans, for Native Americans, for women. We still do not see that occurring broadly at either NIH or FDA. That's after decades of work. We're making progress, but we're not there. So the fact that the legislation that started all of us, and many of us worked on the requirement that there be race and ethnic and gender parity in all of us, didn't mean it was going to happen. And it has happened. It's been a focus, and that invitation was the critical first step. The second reason that we're very involved in all of us, and we're investing a lot of our resources in this effort, is back when we wrote that report, Genes, Culture, and Health, the reason we wrote it was we knew that this was the future of medicine, and we were concerned because once again we saw a health disparity happening. Back when we wrote that report, particularly looking at non-European descent, it was only a few percentage points. We really, as you saw from the slides before, we really have not moved the bar very far in genome-wide association studies. We still really are just a few percentage points. I would argue, given our proportion of the US population, that's a rounding error. And that's unethical. Not only is it unethical, it's bad science. So we're in this because we want this to be the first national research study that doesn't include our populations as a minority representation. We want our populations to be a majority representation because that's who we are in this country and that's who we should be in this database. The third reason I would say that we're involved is we think this gives us an opportunity to explain that this is not only about a civil rights imperative, this is about good science, it's about good medicine, and it's about delivering the right care at the right time when an individual is in need. Now, I say that because when we talk about inclusion, folks kind of understand the ethical part of it. But when you start talking about the science, the connection isn't there. And this is an opportunity for the country to understand that the future of medicine, the future of health, and advancements in cures for Alzheimer's for non-Hispanic white communities depends on the participation of other communities in this type of research. Because what moves science forward, what moves cures forward, are not the majority reflection of the genetic database, it's the differences. It's the gene variants. It's something that looks different. That's where the exploration happens, that's where the study happens, and that is where we're going to find the cures. So very much, we're hoping that this study will finally demonstrate to our national research enterprise that the way they've been conducting business as usual, it's unethical and it's bad science, and that this is the way to do good science, and that's why we're engaged in this effort. Thanks.
Good morning. In National Minority Quality Forum. I'm excited to be here. I am a grandmother of the National Minority Quality Forum. It was born out of the Congressional Black Caucus Health Braintrust, which I ran 30 years ago. But I want to thank Gary and Donna, Congresswoman, for all of their support over the years. I want to begin this process by giving a shout out to all of the nurses in the audience and all of the National Black Nurses members. We're talking about what all of us research is about and about clinical trials, and I say this because the nurses are the most trusted healthcare professional. And so the way that we're going to get all of you to be a part of all of us is because the nurses are going to help you, educate you about the All of Us program. In the early 2000s, Dr. Ida Spruill, Dr. Bernice Coleman, and Dr. Joyce Newman Geiger, all researchers, were very much instrumental in getting information to our members at our annual conferences about genomics and the genome and about genes and the impact that gene therapy will have on our healthcare. And as we're seeing, it's coming to fruition. So that's what the National Black Nurses Association, and that's the reason why we're so invested in this program, in this All of Us research program. We're invested because we know that the nurses are going to be the ones that are going to keep our people compliant, the patients, our partners compliant in the healthcare regimens as they're a part of the clinical trials. We know that there are underrepresented groups like Blacks, African Americans, like Latinos. We know that the LGBTQ community is underrepresented. We know that the older Americans, the old, are underrepresented as well. They need to be a part of this program. They need to be enrolled in the program, just like we all need to be enrolled in the program. We know that African American women have the highest rate of breast cancer, and particularly triple negative breast cancer. They die 41% times more than our white counterparts. Yet we also know that they are only a part of clinical trials and 5% in the clinical trials in this country. Why is that? We're underrepresented. We want to make sure that things change. So the National Black Nurses Association was excited to be a part of this cutting edge. We were right there in May. When it launched, we were right there. Actually, we started in 2017. We had representatives from NIH to come speak at our annual conferences over the last 2 years. And our nurses decided that they wanted to be a part of it. So we've had 13 of our chapters to be a part of this program. They've done some extraordinary things, particularly, I'm going to give a shout out since they're here to our Pittsburgh chapter. We appreciate you all being a part of it. I'm sure we'll get to that part a little later on in terms of the kinds of things that we did, but our nurses, our chapters were very innovative in how they reached out to the nurses and to the community. I'll just give you a little tidbit on that. So imagine being at the University of Alabama football game. Over 100,000 people at a football game. And you're at the tailgate party, getting your ribs on, going around walking, shaking hands with everybody, and handing out literature on the All of Us research program. That's how the nurses do it. Thanks.
So good morning, everyone. Gerren Wilson, Genentech. Now, Dr. Millicent mentioned she's the grandmother of National Minority Quality Forum. I would say she's probably an older sister. For me, I'm her younger brother, and she's welcoming me to the event. So I'm pleased to be with the panel and pleased to engage in this discussion with all of you. So as I mentioned, I work at Genentech, and we are a biotech company in Silicon Valley. And from that perch, we have the really unique perspective to kind of observe the investments that this industry is making to power the future of medicine, which is really going to be a future that is personalized, that offers personalized solutions to patients when you have serious and life-threatening conditions. We have this kind of amazing convergence of new technology, big data, this computational ability to understand the insights that we're gathering and pulling together from these big data sources, and the ability to combine that with the medicines that we have been producing as a biotech industry player with the likes of Amgen and others of you that are in the room, as well as the sophisticated diagnostic ability to really understand the nuances of disease, kind of what is a cancer cell that's next to a healthy cell and how to pinpoint that cell and deliver care. But to the point that the panel has raised and some of the comments that were echoed in the previous panel session, the strength of that science is really powered by the diversity of the data that feeds that engine. And I think that's something that we've realized at Genentech, is that our ability to help invest in this type of future that many players are seeing and that we're aspiring to create is only as good as our ability to connect with patients and develop those partnerships that bring people under the tent, communicate the value of participation, particularly in clinical research, and have these type of conversations in rooms like this and at tailgates, like Dr. Millicent mentioned, to make sure that we are putting ourselves in the best position to create this future that can really change the course of disease. Alphonse, you mentioned that this is good science, and that really resonates with me. So my core focus areas are personalized healthcare and advancing inclusive research. And within those spaces, we've realized that in order to do both well, we have to engage the community to achieve our goals. And as it relates to inclusive research, part of the moniker for our efforts in that space it's a moral obligation and a scientific imperative. If you don't have diverse data, you can't understand the nuance of disease. You can't effectively map health, wellness, pathology, and treatment interventions and understand how, if I show up with an issue or my parents show up with an issue or if Alphonse and his family shows up with issues, how do we understand what's truly noise versus the signal that should be addressed that can be tailored in a very personalized approach? So we're happy to be a part of these conversations to really drive awareness specifically to patient groups. And I think it was mentioned and was echoed by, I think it was Brother Johnson earlier, that we haven't been in the room, we haven't necessarily had a seat at the table at these large organizations and companies that are investing billions of dollars to try to get this right and figure this out. But I can say now, based on colleagues in the room that I'm looking around and seeing, we have a seat at that table now. And we're bringing the diversity lens and commentary to the discussion. And we've been able to localize that at the core of our business to talk about you can't do your science really well, your scientific imperative, if you do not have the strategic asset of diversity within the data sets to get the science right. And that's resonated across our organization. It's allowed us to galvanize leadership that shape the scientific agenda, that decide where we invest our resources, to communicate with patient groups as well as our clinical community and our partners within the broader industry. We've been able to make that argument, and it's resonating, and we're able to continue this conversation and hopefully identify partners in this room to figure out ways that we can continue to make sure that patients understand the value of this work, that our clinical community understands that Genentech and a whole host of other companies are investing in these type of discussions to make sure that our science is better and to make sure that we can truly bring personalized healthcare solutions to all of us. So, pleasure to keep the conversation going.
I'd like to thank our panel for those introductions, and I'd like to especially thank you for keeping it brief. You guys make me look good. So with that, we'll start with our first question. For all of our panelists, this is for all of you. So in terms of precision medicine, is there a minority health imperative, and how does the All of Us research program play into that?
Yeah, maybe I can just kind of keep the party going on that conversation. So yes, I think I would say that there is a minority health imperative. It's a strategic imperative for the success of our investments in personalized healthcare. I think to Alphonse's part, people kind of get the moral piece of it, the ethical component of it. It feels good in conversations, and, particularly in the Bay Area where, it's a room full of people that don't necessarily represent the majority of the folks that I see in this room. But what has happened is that, when you're in those conversations, folks will say, yeah, that's the right thing to do. We feel like there's an opportunity to address health disparities, and that's good. That's something that we value. But it doesn't necessarily change behavior. And I think what we found that allows behavior change, that allows us to set new expectations for the way that we conduct clinical trial research in terms of the clinical studies that we run, that have allowed us to influence the priorities for the investments that we're making in real world evidence. I think what has allowed that to really move forward is to talk about how diversity in the data that we analyze helps us better understand disease, just point blank. And if you think about the African genome, it's the oldest, most diverse genome that we can examine. So when we do these GWAS studies, you have to have diversity to understand what is truly a driver or some new target for a cancer that we haven't examined in the past, or B, what does that look like, in the cancers that we do know? How do we understand how, I would relate to disease and my disease experience, how that differs from, Justin's experience with disease? And that helps me and it helps Justin. And I think that's something that we've realized. So I would say that diversity and inclusive research and bringing more representative data sets into our research environment is a strategic asset and an imperative to make sure that that personalized healthcare can be realized.
I think the driver actually is going to be the nurses. Listen, let's be real clear. The nurses are the ones that have been educating the communities. They, first of all, educate each other about the importance of precision medicine and what all that portends for right now and for the future workforce of this country. It's important for the nurses to better understand and for all of us to better understand that they are the most trusted healthcare professional. They are the ones that are talking to the patients, the partners, more often about what all of this really means and how to get into the clinical trials. They're the ones that are helping the partners, the patients, to stay on their, to get the data, first of all, collected. They're the ones that are asking the what, when, where, and why kinds of questions, and why it's important for the patients, the partners, to be a part of the clinical trials and to be a part of the All of Us research program. And then finally, they're the ones that are calling, texting, emailing, and making sure that they're staying on their regimens to make sure that they are hopefully helping and getting the right data that we'll need, that you all will provide, that will help get us all well. So we're going to need more nurses in order to do this, and we're going to need more nurses as clinical trial coordinators and more nurses to educate even more people themselves, as well as more patient partners. That's what the real deal is in terms of driving the data and making sure that we get more data to hopefully get more personalized healthcare.
Well, I'd say Millicent was biased if she wasn't right. And actually, you know, I would phrase it a little different than a minority health imperative. It's, you know, including all of us is so important for, and we've already seen it happen in several ways. In fact, I remember speaking at a conference and a nurse coming up and telling me when we were talking about some of these issues, you know, she said, I know my patients are compliant. I know they're doing what we're asking them to doing, but the treatment's not working the same for them. And, you know, that really got me thinking. We focus so much on patient compliance. What if we're telling the patient the wrong thing to do? And we have evidence of that. You know, as we've gotten into this, we found rapid and slow metabolizers. We have, my favorite new genetic finding, the aging process at a genetic level is slower for Hispanics. I'm thrilled.
We don't crack either.
That wasn't for me to say. And the thing about this, as these discoveries happen, you know, the thing that has always driven me crazy about the field of minority health is that the outside takes it from a factor of what's going wrong in those communities and how can it be fixed. Nobody ever looks at what's going right in our communities. And what does that mean for other communities? And I think this is an opportunity to start looking at some of those issues.
Just empty.
I agree with everything. This is great.
I think it'll be important, though, for us to follow up with how does the All of Us research program specifically help to achieve those goals of minority health and inclusion in precision medicine. Justin?
So, you know, I think your opening statement, you said a very important thing, and that's folks were invited. And so I'm a member of the LGBT community, and I've worked at the NIH for 12, 13 years, and this was the first time where I saw my community be invited to the table at the beginning as well. And so there's a personal part of the All of Us research program that anybody that's working there, we all have this connection. And I think what we'll be able to do is as we get more folks involved in the program, we're not just saying, give us your data, give us your biospecimens, and then see you later. We're engaging with them throughout, and we're teaching them about research, about what their data they're giving, what that could do for folks, and how we're using it. And I think that will be something that you can use if, you know, we can use the All of Us research program as a platform to get involved in other clinical trials or other research opportunities. So besides just us getting the data, us putting that data out for researchers and driving cures from that, we can also help folks understand why it's important to be involved in research across the board. So it's, to me, one of the values of the program.
To follow up with that, if inclusion at its core is important for the success of precision medicine, not just for minorities, but for all of us. Mm-hmm. What are the clear policy, advocacy priorities that members in this audience and this organization should know about, should be doing to push this forward, to push our agenda forward for precision medicine, for minority health, for the All of Us program?
Get more nurses.
Well, one, I would say lead by example and enroll. It's allofus.org, or if you want to go to the Latino site, it's allofus.org/juntos. But example's important. So I would say, and also it's important to know what the process is like if you're going to talk to anybody about the process. I don't think I was so happy as yesterday. My neighbor came and told me that after church he had enrolled for the All of Us program because there was a table of these bright and energetic folks talking about it. And that was some of my staff. I was so thrilled because it's starting to happen. It's starting to happen, and I'm so thrilled in a scientific endeavor to be able to not only do work at our federally qualified community health centers, but we're just like Millicent said, we're everywhere, and that's where you need to be. I mean, we had in California, Maya Cinemas was a great partner. It's a Latino-focused movie theater chain, and we had the All of Us van out there before family movie nights. We've been at churches. We've been at pretty much every community event that you can imagine, and we're really focusing too on the diversity of the Hispanic community. This past month, we've shown up in places that folks were not expecting us to show up. We've been in Lexington, Kentucky, Omaha, Nebraska, Jonesboro, Arkansas. We've been going places, and people are saying, "Why are you going there?" Because it's where we live. That's what we're not getting, is that we are everywhere, and we are trying to focus not only on the population diversity within the Hispanic community. We're also trying to focus on the economic diversity, and we're also trying to focus on the geographic diversity to make sure this is really inclusive. And the reason I say that, wherever you are, be it a medical center, be it an academic setting, be it in some other kind of clinical setting, or be it in any kind of business, you can be a part of this. You can sponsor an All of Us lunch. You can sponsor an All of Us coffee clutch. You can sponsor something, and that's what we're asking our members to do. We're not telling them, you need to use this model. We're asking them, what's a place where people gather? Zumba groups are my favorite where this is happening. So I would say that's our imperative, is to get involved. Join, see what the process is like, and go tell somebody else about it.
I would just add to that. I think some of our priorities for the year at Genentech as it relates to this particular space is there's three main things. So number one, we're trying to work within our own organization to get a clinical trial or a clinical research policy that would support our employees as a function of our health benefit. So we want to make sure that if people get sick or if they don't get sick, that there's a policy kind of wraparound support so that people understand what they're eligible for, and that there's benefits that support whether or not that they need to take off of work or just do things that are specifically related to participating in clinical research. Our second priority is just educating patient groups and just driving education. I think it's not lost on anybody, those of us in this room, that there's a lot of work to be done to just talk to various communities about this particular space and our aspirations and the relevance to the future of healthcare. So we're certainly trying to be a partner with that, with organizations in this room to just enable that exchange of information and create spaces where we can share information, because there's a lot of mistrust, and I think folks on the previous panel just mentioned that the nature of the mistrust that exists and the need to do some myth busting. In this area. It's funny, so my boss, she's actually in the audience, Quita Highsmith, she tells a story about her husband when she was, they were considering getting clear to get through the airport. And, for those of you that don't know, clear asks for information. And so, as a part of that exchange of information, there's questions that people can have about if I give you this information, whether it's, kind of, a fingerprint scan or whatever, like how would Clear really be trying to use this information? But when they see the benefit of it, like, hey, Guida, she got clear and zips through the line and, is, on her second drink at the lounge before, Quincy makes his way through security. So I think that happened like 1 or 2 times, Q, and then he got clear. Yeah, so I think that kind of just underlies the fact that when you have this conversation in a way where people understand the benefit and we can break it down in a way that really resonates, I think people will want to participate. And we've seen that in some of the work that we've done as it relates to clinical trials. And then the third part of our effort is, it starts here in this room, and I'm sure the conversations we'll have after this is building coalitions, just getting groups together that are diverse and broad and come from different backgrounds and experiences, and create environments where we can have these kind of conversations like NMQF has been so successful at doing. Like, we want to be a part of, enabling some of that stuff as well. I know Amgen was in a room, so it's, a good kind of fodder for us to, kind of start with all of you to set that up. We have we've invested in putting together an external council for inclusive research. There's a couple of members from that council that are here with us this over the next couple of days. So that's an example of how we're trying to just create space to keep this conversation alive, figure out ways that we can attack this issue. Because there's a lot of work to be done. That's just kind of on the external facing. Inside at Genentech, we're really just trying to clean up our act. We've heard the stats around participation in clinical trials. We're not that better, in terms of recruiting diverse patient population. And so I think for us, it kind of connects to, and I think it was Dr. Christensen or Arundel, you guys mentioned the fact that, the root of all of this is injustice. It's institutionalized racism, some of those things. The way we I soften that conversation internally is unconscious bias. That's kind of a way where it's, it's not as confrontational, but I guess it's more of the manifestation of some of those kind of deep-seated, deep-rooted, issues. That unconscious bias, and having people think about how they may be introducing bias in the way we've done research in the past, or the way we engage with communities now, helps people, gives them an avenue to participate in the conversation and change how they work.
I was going to say, those advocates, let's make no mistake, we have a central role to play in protecting the ongoing privacy of this information. Make no mistake about it. This is going to become a very valuable database, and there are going to be folks who are going to want to use it for purposes other than health and advancing science. And as advocates, we're going to have a role to protect and defend NIH in keeping that information private.
Thank you for that. So we've talked a lot about the science of precision medicine. I want to switch gears a little bit to talk about the practice. And as was alluded to in the first panel, much of this is controlled by access. So when we talk about precision medicine, we're talking about cutting-edge therapies, we're talking about diagnostic tests. Millicent and Adolph, can you talk a little bit about, in terms of advocacy for access in the practice of precision medicine, your thoughts?
Sure. One of the beauties of working with the National Black Nurses Association is that we are advocating for nurses, clearly, and we're advocating for the patients that they serve. And one of the beauties of that is having partners. So we've been partnering with a number of different organizations, like the Movement is Life Caucus, like the Association of Black Cardiologists, like United Medical Center, which is in Ward 8 over in Anacostia, to have these conversations about unconscious bias, about institutional racism, about those things that are detrimental to the underrepresented populations, and work with them as our partners. And so the chapters, the 13 chapters that have been a part of this All of Us research program, have worked with a number of community-based organizations, the Divine Nine being one group, hospitals, faith-based organizations, social organizations like the Links, like Jack and Jill, to be a part of this All of Us research program. That's how we're able to get that information out. That's how we're able to get to thousands and thousands of people about the All of Us research program. And it's important that we collaborate with our partners. The nurses can't do everything by themselves. We're some mighty people, let me tell you. But we can't do everything by ourselves. And that's one of the reasons why we have partners all over this country that help us to get the word out, and the word out about precision medicine and the importance of our partners, our patients, being a part of the campaign about the program, and the importance of getting that information back to your communities and to your friends. You know, so often we let that information sit and kind of resonate within ourselves, and we need to get that information out to any and as Adolph has said, any and everybody that we can. One of the beauties of the National Black Nurses Association, again, is that one of our chapters just went to her pastor and said, today is the day that we need to have a church-wide conversation about the All of Us research program. And that's exactly what they did. And from there were other churches in the Bay Area that they took that message to. So those are the kinds of things that we do on the ground. And that's what the Black Nurses Association does every day.
And, you know, I would say as advocates, there are several things we need to keep on our radar screen. One is privacy. The second is we're having a big debate about access in general right now, and we need to be a part of that. And the third thing I would say, and this is where I think we could really lose the fight in precision medicine. At the very time when science is moving to precision medicine, our purchasing of medicine is going in the opposite direction. We're going to bulk purchasing. We're going to value-based purchasing. We even have requirements in some states and a proposal at the federal level that patients would have to fail on the lowest cost therapy before they can go to a therapy, even if their provider knows that perhaps more expensive therapy is the right therapy for them. Prior reauthorization. So we have to consider where we're moving. In science, we're moving towards precision medicine, the right medicine for the individual at that time. In purchasing, we're moving the exact opposite way. And I think that is going to be a major policy fight for us as advocates to make sure that if we finally achieve an area where we don't have a disparity in science, we can't let there be a disparity in access. And I think purchasing policies are going to be a major part of this fight.
With that, I'd like to invite each member of our panel to give one sentence, on the key point for this audience, while I invite all audience members who would like to ask a question to come to the mics.
Thank you, join all of us at joinallofus.org. Thanks.
Tell a neighbor.
Work with the National Black Nurses Association.
Work with the National Black Nurses Association.
Thank you all. To take our first question.
Thank you all for a wonderful panel. This is actually a topic that's near and dear to my heart. So I am trained as an African-American geneticist, and specifically I'm a clinician scientist, so I'm a genetic counselor and a researcher. And in my current role, I have the opportunity to sit at the table at 23andMe, where every single day I'm the voice, I'm the champion for my community, because I want to make sure that the decisions that are made with the understanding of how they could impact my community, people who look like me. So I was very glad to hear you talk about privacy concerns, because as I usher individuals into research, I'm always conscientious of the fact that we're building trust in big data, but those privacy concerns linger. So I was just wondering if you all can talk about like some of the tangible conversations that we can have with people around privacy today to help boost their willingness to get involved in research. And then also if you can tell us how quickly will we see some of these resources that will result from the All of Us research project? Because we know that research oftentimes takes decades before we will actually experience it individually, but will this be accelerated through the All of Us research project?
You know, on the privacy question, as you can imagine in this environment right now in the Hispanic community, asking folks to give up a whole lot of personal information to a government entity. So, you know, we talk folks through the privacy components that are in there, how their data will be protected, that they own their data and they can always have access to it. But the central thing is it a nurse in the room that they trust? Is it a minister in the room that they trust? And frankly, we're putting our good name and our reputation on the line. The trust really, the systems that are in place help. But when it really comes down to it, it's the person asking. And do I trust that person that's asking? So it's a lot. And which is why we're so focused on what are the dangers to this and, you know, organizing as advocates to make sure that we do protect privacy and that what we are vouching for is actually the product that will be delivered. In terms of delivering information, you know, and it's why I appreciate being invited to be a part of the design of how this rolls out. There is a lot of effort being made to make sure that the data is protected but that it will also be accessible so that we can speed science. The whole point of this is to speed research, to speed cure. And one of the ways that the program is going to try to make that tangible for participants is right now we're working out the final protocols so that individuals will be getting back information about the information that they've donated on a regular basis. So, you know, so many research studies, you participate and then you never hear from the researcher. This is being designed to be different so that people will hear on a regular basis, not only about research, but that they get information about the data, their own data that they've donated, you know, what has been found in running some of the analysis.
Just one point on the privacy and security. I mean, this is something that we talk about every day in our office, and we are very aware of the concerns. We're very aware of the trust folks are putting into us as the program, and that we have an imperative to protect this information as best as we can. We do have, through the Cures Act that was passed in 2016, we do have what are called certificates of confidentiality, and basically any of our researchers that are using this resource, they fall under that. So we aren't, those certificates protect us from access by law enforcement agencies and the like. So it's another added layer of defense. I think the one thing to think about is you know, as you build any large research or any large resource with a lot of data, it just becomes more a target. And so we are looking at this as what are we building today? What's the security today? What is it going to be tomorrow and the next day? And just continuing to iterate on that and trying to be one step ahead of the folks that want to use this for bad purposes.
And to your second question in terms of tools, so I can give an example on work that we're doing in neuroscience. We're actually doing this work in collaboration with Dr. Mitzi Williams, who's in the room. So this is a program where we have patients who have multiple sclerosis. They're able to sign up to participate in this research program. And it's a collaboration between Genentech, Picnic Health, and our neurology community. And essentially what that does is if you've been diagnosed with MS, Picnic Health will go and aggregate all of your electronic medical records from all the physicians that you've seen over the course of your life, and put that information in a user-friendly database or portal for you to have this view of the history of your disease. Now the research adds for us, so that's one kind of immediate immediate resource that we provide patients that are a part of that study. I think I would say more short-term and to a certain extent medium-term impact of that is once we kind of get more patients into this database and into this repository, that data will start to be analyzed for triggers for disease. What's triggering exacerbations? What are some of the elements that were causative to the progression of their disease? These are some of the things that physicians and neurologists can then be empowered to counsel their patients on certain conditions that may stimulate an exacerbation, and then also help them tailor their medication to ensure that the medication's deployed in a way to address some of those issues. So that's something it's almost like a kind of a real-time gift back to the, I wouldn't say the gift, but like a real-time value add given back to the patient, but also this kind of back-end kind of research process that's really at the crux of what we think about when we think about personalized medicine, which is there's the genomic component, but there's also just all these digital tools that we have at our disposal to get that to patients, create mechanisms for them to access it, allow them to benefit from the use of those tools, and then allow the research community to analyze that information to develop better treatment approaches.
Thank you for that, Dr. Wilson. So I've been given a 5-minute warning, so I'd like to take a question over here, and if we can try in a rapid-fire format with only one panelist answering a question in the most succinct possible way. Thank you.
So, good morning, and thank you for the timely and necessary discussion. My name is Miranda Ward, and I'm an assistant professor at the George Washington University, and one of this year's 40 Under 40 Leaders in Health. So, as we know, historically, science and medicine has been, erroneously used to substantiate racist ideologies and policies. And even after the human genome was completed, that demonstrated there's no biological basis for race. That hasn't necessarily translated over into medical practice and then training programs. So the question for the All of Us program is, what plans do you have underway to distinguish between race-based medicine and precision-based medicine? Especially given the conversation we're having around privacy, distrust, and then as well as communities like mine that, as I'm trying to align myself with the work that we know is necessary, but we know there's some challenges there.
Justin?
Yeah, that is an amazing question. I mean, it is the question, right? We as the program are collecting this data from our participants. We're going to make it available for researchers, and when we say researchers, we don't mean those just at George Washington or at Harvard, but folks across the country that have a question that want to ask and use our resource. The problem is that there's sometimes bad actors that are going to go into any type of data resource, and they are going to find the pieces of data that fit with their preconceived notions. That is not an excuse, that's just a fact. So one of the things that we are working on, we've been working with our community partners to get out word about the program, to talk to communities about the program. We also want to work with provider partners to go to physicians, to go to doctors and talk to and nurses and other caregivers and talk to them about this is the type of, this is this program, this is what we're finding. These are the type of resources that are available. And we need to talk to our researchers about this as well. And I think one of the neat things about this program is when you come in as a researcher and you say, I want to look at folks that smoke in their 40s and have cardiovascular disease. That topic, once you submit that's what you want to look at, that goes on a public website. So we can all see that that's what you're researching. And what that allows is for other researchers to come in right behind you and say, I'm going to look at the same thing. And I think that will be one of the ways that we help that we can have this open so folks see where the data is coming from, they see what people are researching, and we can immediately follow up and do additional studies.
Thank you. So we've now entered our lightning round, so 1- and 2-word answers are very well appreciated. Next.
Good morning. Sam Marcy, I'm past chair of the National Hispanic Medical Association and presently member of the Governing Council for the Minority Affairs section for AMA. you may think I'm a brain surgeon, but I'm not. I'm a family doc. So I'll throw that out there. I think that it's about relationship. And I certainly, I see so many hand-picked, cherry-picked people going into studies, and I think it's the primary, so I'm going to suggest another driver for the bus. And it's the primary care physician who establishes that relationship with the patient and can get that patient to trust enough to be able to become enrolled. Because otherwise, we're taking all our studies to Latin America, where the patients are still not the same as we see here. And so I think we should be doing more here, but empowering perhaps the primary care physician to be able to recruit individuals for some of these studies so that then we can collect this data. So I'd like to hear your comments.
Yeah, I mean, our network, we have a network of community health centers and clinics that just within our network serves 15 million Hispanics every year. So we're training our provider network and we're setting up protocols so they can also make referrals to certified health educators within all of us. And we've been working with the All of Us program because one of the problems we found is right now we have to, if somebody becomes interested in a community setting, we have to send them to Walgreens or Quest or some other place. We're working out a protocol now with NIH where we can actually have All of Us Week and providers in their office can have the enrollment team. So that is much more consumer friendly and involves the clinician and connects up to the clinical setting. And I think you're absolutely right about primary care docs bring a critical component. And we're working right now to train our network, certainly.
Thank you. A question over here?
Sure, thank you. Sue Peshin with the Alliance for Aging Research. And I had a question. There's been inclusion policies at the NIH for a couple of decades for minorities and women, and then more recently for inclusion across the lifespan. And you have amazing partners with this All of Us program and a lot of different approaches being taken to try to recruit folks. And I'm wondering what you're doing to sort of compile all of that and talk about what works, what doesn't work, to help inform the inclusion policies at NIH and also help create awareness with industry as well, who does, puts far more investment into a lot of clinical trials and has a big problem with recruitment. So are you guys actually using these great examples, to kind of compile all of that for use? And then my second quick thing is just in terms of evaluation from the folks who are signing up, are you asking them throughout the process, how is this for you? Is there anything that we should change? Because, a big part of involving folks in research is getting their feedback on how you're doing the research. Thank you.
Very quickly, yes and yes.
Thank you so much.
Happy to chat later.
Our last question.
Yeah, I don't have a question, I have a commentary, and if there is an answer, I will appreciate it. But my name is Manuel Puig. I'm in San Diego. I am an ophthalmologist practicing in Chula Vista, and I do retina, anterior segment glaucoma, in which I have a fellowship. Obviously, it's very important that in our medical trails, which dictate the preferred practice patterns that we use and are recommended by the American Academy of Ophthalmology, we need the clinical trials. And we have a lot of very strong clinical trials in ophthalmology, and they are very strong and powerful because they have a lot of patients and they have been performed during many years. Curiously enough, in all these medical trials, the number of Hispanics, for instance, and most of my patients are Hispanics, and African Americans is very limited. And there are two very important conditions in ophthalmology that are the main causes of irreversible blindness. In African Americans and in Mexicans is glaucoma. Glaucoma is very frequent and very serious in African Americans, and in Hispanics, the incidence of glaucoma increases significantly with age to the point that it surpasses the prevalence of glaucoma in African American populations. The other disease is diabetes. And diabetes, as you know, is the main cause of irreversible blindness in the world and also affects Hispanics and African Americans. And these medical trials, which are very important, powerful, and have changed the practice of ophthalmology, are based upon the data obtained with a minor contribution from these minority groups. So we have two sides of our brain, the one side in which we said, well, we need to practice evidence-based medicine. On the other side, we need to practice what I would call practical medicine. When you see an individual that comes with diabetic retinopathy, and you need to start treating with injections of Avastin, but the patient fails and doesn't come and does not return, and returns later, as you can see, sometimes even years later, with a terrible condition that is going to limit, if not produce blindness, limited vision, if not produce blindness. Well, there are other alternatives, which are not now the best recommended practice patterns, which is pan-retinal photocoagulation, which has more side effects than injection, but it can produce definite changes, lasting changes that will prevent blindness in these patients. The other condition is angle closure glaucoma, which is very frequent in African Americans, in Hispanics, Mexicans, and Asiatic people. And the American Academy recommends the use of laser iridotomy only when there is certain air extension in degrees of the angle closure. But when you see a person that is 40 years old that has obvious critical narrow angle and focal areas of angle closure, and you say, well, shall I wait? Shall I treat it later? Well, better treat it now. This is a person that might not have the opportunity to return. You briefly mentioned how to apply all these clinical trials with the very important information that guides us. Well, in practical terms, we need more contribution of the minorities, and then we can have a better understanding on what happens in a group of patients. I also want to make a commentary that 25% of the physicians in the United States are foreign graduates. So we also need not only nurses, but we need physicians. And our patients also have a great deal of confidence in physicians, and they sometimes, at least in my practice, consider the specialist, the retina person, as the family person, family practice that is going to guide where shall I go when I have pain in the back, things like that, Finally, there is one more issue that is very sad, and is that there is a minority prey medicine. I have a patient right now that is a lady. She is documented in the United States. She traveled to Mexico and was found, because she had headache, to have an embolus or aneurysm in the brain. And she comes here, is in the hands of a family practice individual who is doing all sorts of tests, including, for instance, and I will be finished. I know.
Yeah, so I'm getting a comment because I think we're cutting into lunch, and this is a group who likes their meals. So I think we will all be here afterwards. What I'm hearing in your comment is the importance of national alliances and taking a multifactorial approach where we include everyone to make sure that we hear all voices at the table, but also that we have leadership from our national alliances. So thank you for that. And I'd also like to thank our panel, Dr. Gerren Wilson from Genentech, Dr. Millicent Gorham from the National Black Nurses Association, Mr. Adolph Falcon from the National Alliance for Hispanic Health, and also Mr. Justin Hentges from the All of Us program. Thank you very much.
Thank you.